Muthiah Vaduganathan from the Brigham and Women's Hospital and Harvard Medical School, and I'll be discussing the late-breaking clinical science on the lifetime benefits of combination therapy in heart failure with preserved ejection fraction. So today, it's been a remarkable period in the management of HFpEF. In just the last 5 years, we have 3 individual therapies: the SGLT2 inhibitors, the non-steroidal MRA finerenone, and the angiotensin receptor neprilysin inhibitor, sacubitril/valsartan, in select individuals. These therapies have distinct mechanisms of action and may have complementary benefits in clinical practice, but few analyses are available to understand what the combination effects may provide individuals living with HFpEF today. So we leverage individual-level patient data from 3 of the trials that examined these therapies. We examined data from the DELIVER trial for the SGLT2 inhibitor dapagliflozin, the FINEARTS heart failure trial with the non-steroidal MRA finerenone, and the data from PARAGON heart failure with the ARNI sacubitril/valsartan. We first understood the relative benefits of combination therapy of either an SGLT2 inhibitor and a non-steroidal MRA in all individuals with heart failure with mildly reduced preserved ejection fraction. And additionally, we undertook a secondary analysis of understanding the combination of all 3 therapies, especially focusing on those individuals with an ejection fraction below normal, because regulatory bodies have put forth that might be the population in which patients may have greatest benefits with the ARNI sacubitril/valsartan. So we found that the combination of an SGLT2 inhibitor and non-steroidal MRA afforded approximately 30% protection against cardiovascular death or worsening heart failure. When we examined those individuals with an ejection fraction below normal, we see that that's expanded further to the combined use of an SGLT2 inhibitor, non-steroidal MRA, and ARNI in the population with an ejection fraction below 60% may provide up to 40% protection against that endpoint. These are large and clinically significant effect sizes and are likely to be meaningful and translatable to patients. However, we further undertook an analysis to understand what is the lifetime benefits. What if these therapies were actually continued for the life course of patients as they're commonly prescribed in clinical practice? To do so, we leveraged actuarial methods to forecast the short-term benefits of a trial population, long-term horizon in which patients live for decades thereafter. And in fact, we found that the combined use of an SGLT2 inhibitor and non-steroidal MRA may provide 3 to 4 years of additional survival free from a cardiovascular death or worsening heart failure event. And again, in that population with ejection fraction below 60%, we see that the combined use of all 3 therapies may afford up to 5 years of incremental event-free survival. So again, this is not only meaningful on the relative scale, but also on the absolute scale. And so we believe that clinicians may use this information to communicate to patients, as well as in shared decision-making about the potential benefits of early upfront initiation of combination therapies. Each of these therapies were evaluated in individual trials against comparators such as placebo. And so we have little data to understand what the combined use of these therapies may provide. And in fact, guidelines are moving towards combination use, much like we've seen in heart failure with the reduced ejection fraction. So we believe that these data, leveraging cross-trial analyses of 3 major trials evaluating the 3 established therapies in this treatment population, will provide clear evidence for the relative and absolute benefits that combination therapy may provide, and we believe this will be informative for clinical care and shared decision-making. Ongoing work related to implementation science about the practicalities of starting 1, 2, or 3 drugs simultaneously are underway. For instance, the recent CONFIDENCE trial evaluated the combined use of an SGLT2 inhibitor and a non-steroidal MRA on outcomes that ranged across 180 days. Again, now the effort really comes on part of our whole community in leveraging these data and now translating to clinical practice and using these therapies effectively and appropriately, but also in an expeditious manner early in the disease course of these patients.